Good morning. So some of you may be saying, what is 90-90-90? And I will get to that. But I'd like to first start this session by telling you it's going to be a little bit different from the last session in that it's going to be a lot more back and forth. It's going to be a little bit more like the second half of the last session where we're really asking for a lot of audience participation. So feel free to ask questions and even just make comments as you see fit. So I wanted to give a brief introduction of my panelists. So we have, I have them in a different order on my paper than they're sitting. So this is Sanyukta Mathur. She's from the POP Council, and her research focuses on the intersection of social norms, gender and empowerment, and social transitions on reproductive health and HIV/AIDS outcomes in sub-Saharan Africa and South Asia. She currently serves as the project director for the Council's DREAMS implementation. That's a program focused on adolescents. And a set of mixed method studies for which examine the outreach and impact of the comprehensive HIV prevention programs aimed at reducing HIV risk among adolescent girls and young women and their male partners. Adjunct professor at Columbia University. And so when I saw that, I was like, oh, is she at Pop Council in New York? But no, she's actually here in DC. We also have Paul Bouey. He is a senior advisor, research and monitoring and evaluation division of HIV/AIDS TB at Save the Children. It's a very long title. In this capacity, he supports Save the Children's Global Fund HIV/AIDS TB monitoring and evaluation activities. Which currently encompass 7 countries in Asia and Africa. Prior to SAVE, he was at the Office of the Global AIDS Coordinator for 10 years in capacities as Deputy Coordinator, Special Assistant to the Coordinator, Director in Strategic Information, and as a Special Advisor for Country Impact. He was a member of the senior leadership team for PEPFAR, which is the President's Emergency Plan for AIDS Relief. And before PEPFAR, he worked as the Director of Monitoring and Evaluation for Pangea Global AIDS Foundation, and Director of Research and Monitoring and Evaluation at the National Native American AIDS Prevention Center, because we have HIV and AIDS in the U.S. too. And he's an anthropologist by training with an MPH from Hopkins. We have Stella Babalola. She's an assistant professor at Hopkins and affiliated with the Department of Health, Behavior, and Society, as well as the Center for Communications Programs. She's more than 25 years of experience in behavioral research and has worked extensively in Africa, Latin America, and the Caribbean. Over the past 5 years, her research has focused largely on maternal health and the risk factors for HIV in Africa. She has conducted research and published extensively on multiple reproductive health issues, including family planning, maternal health, sexual and gender-based violence, adolescent sexuality, and HIV. Then we have Marelize Gorgens working at the World Bank in the Health, Nutrition, and Population Global Practice. She's a senior member of staff, manages an HIV efficiency and effectiveness global program. She's the PI on 2 large HIV impact evaluation, and she has numerous publications on HIV-related topics. So we have a very wonderful panel this morning. And the way that I was going to structure this was I was going to throw out a sort of an opening question and ask the panel to have just a couple minutes to respond to the question and then open it to the floor. So I have 3 basic questions. One is centered around the populations, who they are. One is centered around the evidence that we have on those populations, and one is about how we can use the evidence that we do have and the data that we do have to get the information that we need for policy impact. And then if we have time, we can talk a little bit about evidence uptake as well. One thing that I wanted to say is HIV is this huge epidemic. There are over 36 million people living with HIV, and that basically means HIV positive. In 2015, 2.1 million people were newly infected with HIV, and 1.1 million people died of AIDS-related illnesses. This is hitting sub-Saharan Africa the hardest, with 70% of the people who have HIV living in sub-Saharan Africa. But those numbers, even though they sound really terrible and huge, actually indicate a huge amount of progress that we have made on this epidemic. If you look at this chart, you can see how many people are receiving antiretroviral therapy now compared to 2000, and it has just, hugely increased over the last, 17 years. In the second picture, another graph of just sort of like average coverage. So you can see this huge growth in coverage of treatment for the people who are living with HIV. This is in no small part due to the PEPFAR program that our U.S. government funds. We've made a lot of progress, and we're talking about this massive change. So in 2003, we were talking about 3 by 5. We were talking about getting 3 million people on treatment by the end of 2005. The end of 2005 came. We had closer to 1.3 million, but it was still quite an achievement. The follow-on goal was 15 by 15. 15 million people on treatment by the end of 2015. And again, we came up just a little bit short at 11.5 million. But it got to the point where we were really talking about a whole new perspective. It was no longer this emergency plan to address this epidemic where people were dying and life expectancy was declining in many countries instead of increasing. We are now talking about the end of the epidemic, an AIDS-free generation, and just the idea of having gone from this epidemic of enormous proportions to the idea that there could actually be an end is a massive amount of progress. The goal of 90-90-90 is the newest goal, and what it means is we have an estimated number of people who are living with HIV or who have the HIV virus. And what we want is 90% of those people tested and diagnosed so that they know their status. And of those 90%, we want an additional 90% to be on treatment. And of those, 90% are virally suppressed. And that means their disease is under control in a way that you can no longer detect the virus in their blood. This is sort of an example, and it's not a great example, but it's an example of how there are differences among different subpopulations. And this happens to be testing coverage. But even among testing coverage, what you'll see among different subpopulations who are affected by the HIV epidemic, there are very different testing rates among those different subpopulations. This happens to be for Asia, where in Asia the epidemic tends to be more centered on high-risk population groups, whereas in sub-Saharan Africa a lot of it is a little bit more generalized to the whole population. So there are certain what we call key populations in HIV. These key populations are at risk in special ways. So either they're much higher risk for acquiring HIV or they are particularly vulnerable in some way that makes it a population of particular interest. So sex workers have, in some places, up close to 10 times the risk of the general population. Men who have sex with men in places have close to 24 times the risk. Also, people who are injecting drugs have 24 times the risk. Transgenders, I think transgender is a little bit hard to estimate, but it can be up to 49 times the risk. Prisoners are also at increased risk. And if you compare adolescent girls to their peers, what you will find is they have quite an elevated risk compared to their male counterparts. And so when we're talking about HIV, I think the difference between this conversation in this panel and the conversation in the last panel is that we're talking about a lot more subpopulations, and we're really talking about differences between different regions. I think this is true for all of the other topics as well, but I think in HIV this is especially important because so much of the epidemic really has these subpopulation dynamics that we have to keep track of. And so my first question is, what do we know about these key populations and adolescents and men, and why are they lagging behind in so many of the different indicators? And what I forgot to mention, and I think others in my panel will talk a little bit about, is that men really are lagging behind the women in this area. And so it is, in that sense, the gendered component within this topic really does center on men even more than women in some cases. That's not true for the adolescent girls, but in some cases the men are also lagging behind, so we can't forget about the males. So what do we know about these people, and why do we think that they're lagging behind?
Thanks for the overview and the invitation to be on the panel. So I think the key populations that you mentioned actually are fairly diverse, and so that's one thing to recognize, that there are different reasons why they're lagging behind. There are some similarities, though. A lot of the populations that are lagging behind in the 90-90-90 goal are situated at the intersection of multiple vulnerabilities, and multiple vulnerabilities that then affect their effective access to care and treatment services. And I think that's the key point to keep in mind. Now, that manifests differently for different populations. For a lot of key populations, so sex workers, men who have sex with men, injecting drug users, prisoners, transgenders, some of the ones that you mentioned, there's been a lot of work, and the Population Council has done a lot of work really around understanding the compounded stigma that these populations face, and in large part due to the criminalization of these persons and their behaviors, and how that affects their ability to access care, or even finding providers who are willing to treat them. So that's a key part of what's happening with key populations. Among adolescents, particularly in sub-Saharan Africa, as you alluded to, the epidemic is it's a generalized epidemic. There's a lot of heterosexual transmission. And for young women, the particular vulnerability is in the intersection of gender and age. So younger women are not supposed to be sexually active. They're not supposed to be accessing HIV services. And so the intersection of that gendered and age vulnerability is often keeping them from seeking testing or seeking care, or providers giving that access and availability to girls. There are also really strong sexual dynamics power dynamics within sexual relationships that limit young women's ability to negotiate safe sex. So that really plays into the dynamic. And for men, I think the issue that you alluded to, that really where men fall behind, is that they are not coming into HIV care early enough. So men do come to care, but they're coming at late stages of their disease where the viral load is high and they have higher mortality outcomes. So what we hear from the work with men that the council is engaged in is that they find the services are not tailored to them. They're tailored for women. They were largely designed around antenatal care or building on those mechanisms. So we really need to, and we often, even when we do gendered work, see men as the perpetrators of the epidemic or violence and internalized epidemic. So there's this intersection of vulnerability that is different from the vulnerability that key pops and adolescent girls face, but that is keeping men away from services.
Before leaping into this too, I want to thank you actually for the invitation and all, and the opportunity to actually see some of you again. It's been quite some time. So what do we know about key pops? I think we know a lot, but part of what we know is that we don't know enough. I think what we see in many cases is given the nature of key pops, who are typically kind of very geographically limited, they're relatively small, kind of in size, and so consequently to actually really know these very local populations, you really have to focus a lot of resources getting to know them. And we really don't have good tools for that at this point in time. That you can look at drug users in some large city, be it in Asia or kind of in North America, South America and the like, and you actually have kind of variation among those populations in these big cities. How well do we know that? Not very well, because typically we just treat it as an aggregate of sorts. Our biggest tool are typically these integrated biological behavioral surveys, which by their nature require larger samples, a lot of resources. They're not cheap, and so consequently you lump a lot of the results that you learn from these. Programmatically, there is a lot to learn, a lot that we have learned, but these typically too are very limited to some key indicators. So not as small as Sarah had cited early for the early PEPFAR, but not much different either. They're often number of people served, number of people receiving treatment, and that's pretty much it. That doesn't give us a real good window into the nature of these populations and the nature of delivering services to them and how they vary. When thinking about some of this variability, I think among what we know of sex workers, there is the differences in venue, differences in age, differences in client types, differences in different parts of the city. Drug users, not dissimilar in terms of the drugs that are used, the availability of different resources, needles, so on and so forth. So, and ultimately too, I think a big driver here is stigma and discrimination. As we've just heard, just criminalization makes it really difficult to actually openly deal with a lot of these populations, although we see it is done a little bit kind of under the radar. You'll see a lot of governments will acknowledge, yes, these are illegal activities, and they just don't target them all. Sometimes they do. Sometimes it'll be the occasional show up and arrest people. But more often than not, they'll let these things happen under the radar, recognizing that this is an epidemic that continues to spread, and these communities are really kind of the hot spot for it. Now, when looking at kind of the gender discrepancies, I'm not quite sure how it fits in, because in our key pop definitions, female sex workers, well, there aren't many men there. Male sex workers, aren't many females there. Drug users are overwhelmingly male, but there is a component of it that is female, so on and so forth. So there isn't so much, I don't see discrepancy other than by definition in terms of the populations we're dealing with. More broadly, absolutely. We see a lot of gender discrepancies that are actually taking place. One thing too, I think that we're seeing that I think is vital here that we don't actually fully recognize is where is the push for a lot of this coming from? And, as Sarah has noted, it's PEPFAR and Global Fund. They both have huge bankrolls for implementing kind of broad-reached HIV programs in a lot of these countries. There's a difference in the epidemic in Asia than there is in Africa, but what we've found in the last couple of years, some of the work that PEPFAR has done, you have a huge quantity of resources going to these programs, testing and counseling. And they were finally able to get data at the local site level and finding for 1,000 testing and counseling sites, maybe a third generated more than 3 or 4 HIV positive people in a year. And in these times of tight resources, you can't afford 2/3, up to 750 sites where you're expending resources and actually getting very little out of it. So consolidating resources, actually targeting where the epidemic hits. And you see in the nomenclature, it moves to discussions around hotspots that you see in countries. There are some places where the epidemic is raging, some places where it's almost non-existent. And well, that's a real kind of familiar. It kind of sounds like key populations, that you've got these core clusters of kind of active infection going on, but now this idea, these principles are being applied to the kind of the more general population. But in fact, they are key populations in the same respect. So I think our mindset has to shift to actually addressing them that way, and also incorporating some of these more vulnerable, stigmatized populations in the same approach. But in that, so as these funders are beginning to shift how hard it is to actually separate that. It's like, give me 12 months, it'll be okay. Exactly. How they target these populations. If you look at particularly PEPFAR, if you look at the funding that is targeting key pops, it's always been very tiny. in part because the key pops have really been targeted to Asia, which has many fewer resources than the African countries do. But kind of even when you're looking across the board, very little money goes to key pops. And so we've got to start rethinking that kind of in terms of hotspots and how do we actually reapply our resources and actually looking at these groups. But great, thanks.
Thank you. Also, I want to say a big thank you for this invitation, for the opportunity to participate in this discussion group. I want to stress first that, yes, the key pops, there is heterogeneity across them, but even within each group, there is a lot of heterogeneity. For example, if you look at the adolescents and young women, some of them are children, actually 10 to 14. They are OVC. Many of them have lost their parents to HIV. So they have multiple vulnerabilities. They are exploited. You have the adolescents, some of which are in school, some are not in school. You have some who are married, some who are not married. There is a lot of heterogeneity that strategies will have to be conscious of the heterogeneity within the group, because, for example, the type of interventions that will work for an OVC might not work for this woman who is engaged in transactional sex, who might be in school, might actually be a university student, but at the weekend, for more pocket money, engages in transactional sex. If you look at the men, the men, for example, it's the huge problem with the men is testing. They just don't get tested. And of course, unfortunately, that is the entry point. So one reason why they might, be lagging behind on all the 90 indicators would be because they don't even get tested in the first instance. And why don't they get tested? Of course, we have talked about stigma. There's the issue of stigma and discrimination. But also, more importantly, there is the issue of masculinity. What makes a man a man? What do men cherish? They want to be seen as the head of the family. They want to be seen as the one in charge. They want to be seen as not weak, but, healthy and strong. They want to be respected. And, you have maybe two main dimensions. There is the dimension of power. There is the dimension of autonomy. And, the man cherishes all that. And when you intersect the issue of stigma, HIV stigma, interact that with masculinity issues, then, this becomes very complex. And so we need to know more about that. Another thing is, when we are talking about what is it that makes these people to lag behind, we need to think about it's not just what is personal to them. It's also relationship matter issues. It's also in the family. It's in the organization, the health facilities, it's the place of work, it's the community, it's also even policy. So there are vulnerabilities, there are barriers at each level that we need to talk about. If you think about the individual level, for example, let's talk about adolescents. Low perceived risk, their powerlessness, the fact that they cannot make decisions, the fact that they are so dependent, they engage in transactional sex, not just because they want to get the latest, but it might actually be for survival reasons. If you look at adolescent boys, we don't tend to look at adolescent boys and those young men, but they are also very vulnerable. Their main problem might be the low perceived risk, the fact that they don't even see themselves to be at risk. Plus, this system, I think we have neglected them for too long. I think researchers we have neglected these boys and these boys are the ones that will become the men. These boys are the ones, that will down the line become, the channels for especially for infecting women. So we also have the issue of fear of the consequences. What if, especially among all the groups, but the fear of the unknown, the fear of what will happen to me, what will happen to my family, the fear of what accidental disclosure, what will happen if somebody knows who I am. So that fear is actually keeping people from getting tested, from knowing their status, and from getting into treatment. Those are some of the issues that we might want to look at. For men, there are multiple issues at the relationship level. When the partner is tested, when the partner knows his status, it's easier for the woman to disclose. It's easier for the woman to get tested also. But the fear of intimate partner violence, gender-based violence, is an issue in preventing women, young women, adolescents from getting tested. We need to look at all this at a sort of socio-ecological level, multiple vulnerabilities at many levels. I'll add some things later. Thank you.
Thanks very much, Stella, and also thank you to 3IE for the invitation to be part of this interesting panel today. I think my colleagues have said many of the things I was going to say, and as the last person answering the question, hopefully I could fill in some of the gaps. So let me try and do that. First of all, I think if we think about these populations and prevention evidence, what works in terms of preventing new HIV infections, there are proven interventions. 5 years ago, maybe even 10 years ago, we couldn't necessarily say that, right? We now know for key populations what programs work. We know HIV treatment prevents new infections. We know that male circumcision works to reduce an HIV negative man's risk of becoming HIV positive. But we don't yet have a full basket of answers. We need more arrows in our quiver of HIV prevention tools to be able to end this epidemic by 2030, which is really what the 1990 goals are meant for us to achieve. Even if we put everybody on treatment, we won't necessarily be successful because there are still things that we need to know and things that we need to learn over and above the prevention tools that we have at the moment. And the point that Stella made about and Sanyukta about the multiple vulnerabilities that these populations are faced with, because many of them belong to more than one category, right? You have adolescents who are female sex workers. We know a female sex worker she's most likely to get infected within the first 18 months of her sex work career, right? When she's not yet a full-time sex worker, when she's not yet self-identifying as a sex worker. This might be a university student that has some transactional sex over the weekend, right? So for those populations, it's really difficult to program for them because they don't yet self-identify under the labels that we give them programmatically, because it's easy for us to categorize people into labels, but people don't themselves necessarily recognize those labels. I think the issue of HIV testing is particularly interesting. I spend a lot of time in Swaziland, and in Swaziland, they estimate that around 75% of women who live with HIV know their status, right? So let me say this differently. 75% of women who are HIV positive have been diagnosed. For men, that figure is less than 20%. And the reason for that big discrepancy in a large part is because men, as Stella said, don't want to get tested for HIV. And if you ask them, they'll say, I don't want to get tested for HIV with a female service provider because I don't want to break down if I learn that I happen to be HIV positive. So on the one hand, we know what works, but on the other hand, we don't yet know enough, and we don't yet have enough evidence around how to reach these populations with programs that are relevant to them and that will ensure that they want the service and that they take up the service. I also think there's opportunity. We know adolescents are surgically attached to their cell phones, right? We know that the potential of e-health and m-health to help them link to care, those who are HIV positive, to help them adhere to treatment, lifelong HIV treatment, if they need it. We know that there is potential and that there's evidence around what could be done different. But I think too often we have 20th century solutions to 21st century problems. We think about adolescents. In Swaziland, again, for example, 60% of young people aged younger than 24, adolescents and young people who are no longer in school, but are unemployed, right? So we call them the out of work, out of employment group of people. And that's 60% of the young people of that age, right? Now, our typical solution for adolescents is we know secondary education is incredibly protective. So let's try and keep as many of them in secondary education as we can. But that will not work for a large segment of that population, because we also know that around 50% of young women aged 17 and older have been pregnant or are pregnant, at least at the time when we did our survey. So for them, going back to school at that point in time to formal secondary education might not be a solution. But there are no good alternatives, right? We have a lot of, and with all respect to those programs, we have a lot of sewing and beading programs in Africa for which there are no markets to sell the goods that are being made through these self-employment projects, right? And I know the DREAMS program, and I'm sure Sanyukta can speak about that, is doing a lot to try and create 21st century job opportunities. But whilst we're trying to deal with adolescents in East and Southern Africa, where there is the highest burden of HIV, we also have the highest, one of the highest unemployment burdens in the world. And unless we can address these broader structural issues, we can't just look at these populations from an HIV perspective, because they live their whole lives. They don't just think about themselves as every day I wake up and I try and avoid becoming HIV positive. They have full, rich lives outside that context. And I think we need to think about them from that whole of development perspective if we really want to find solutions. And the last point that I think, which is maybe the elephant in the room that we need to acknowledge, is that yes, evidence is important, but beyond the evidence, there is a political economy dimension to programs for these key populations, right? There are countries in Africa that have recently enacted legislation that makes MSM behavior or MSM activity, or even knowledge of MSM activity, men who have sex with men who are in relationships with other men, who makes even knowledge of that activity illegal. In Nigeria, for example, if you know of a gay couple, there was a group of people recently who were arrested because they went to celebrate the wedding of a gay couple. They could be arrested. And as long as we try and program in those environments where it's not just illegal, but there is a culture of unacceptance, I think it's about more than the individual stigma that people face. There's real institutionalized stigma, and it is hard to program for these populations in those contexts. It doesn't mean we shouldn't do that, but it's just really difficult to do that. Thank you.
Hi, Jill Gay, What Works Association. We have the website whatworksforwomen.org, which is the evidence base around gender and HIV. And just to note that agreed with everything you said, but the most important factor is going to be political will. So for example, in New Zealand, sex work is legal, and police who rape sex workers actually go to jail, which is miraculous for any of us who have worked with those populations in other countries. In Vancouver, Canada, where there's safe injecting services, as there is in Sydney, Australia, there aren't high rates for injecting drug users. So these are not mysteries. It's a matter of having a human rights framework. So I think that's an important piece of the puzzle. We are lacking in data on transgender, on what works with transgender, because it's been such a marginalized population. But Viv Healthcare is starting to fund some of that work. So I just wanted to raise that issue.
Thank you very much. Richard Manning, 3IE Board Chair. I'd just like the panel to comment, if they would, on whether there is or isn't a financing issue here. Is the issue basically one of stigma, discrimination, the difficulty of doing it? You've said there are now known packages of prevention, or is it a financing one? If it is a financing one, is this an area where it makes sense for at least some governments to look at borrowing money for this, given that there will be a very large saving in treatment costs if prevention is effective?
Thanks, Jill, for your comment. I'm not sure if there was a question there, so I will take Richard Manning's question around funding financing. I think the answer to your question is yes, there is a funding financing issue. Within the HIV field, there has been new biomedical interventions. So most notably, currently, there is a treatment available called PrEP, pre-exposure prophylaxis, that actually, if taken and adherent, you can prevent individuals from from acquiring HIV. So it is quite revolutionary. There have been multiple demonstration projects. There are real-world studies going on. And the key issue right now for that amazing biomedical intervention is around financing, around figuring out how lower and middle income countries can purchase this drug, support the use of this drug, and save costs related to treatment later for people who do get infected. So there are, at multiple levels, funding and financing issues that need to be addressed and brought to light, particularly in this current environment. The US government and PEPFAR program particularly has been a huge supporter of HIV programs and doing really innovative things like the DREAMS program, which does do some of the things that Paul mentioned. It has focused geographically on areas of highest risk. It is targeting a population where HIV prevalence rates have not declined for the last 30 years. Where that gap between boys and girls' HIV prevalence rate has stayed stagnant. It is targeting key aspects not only of individual behavior, but social support and economic support that girls need in order to get access to these services. And it's bringing in new biomedical interventions into the mix. So it's doing all of those great things. The issue now is how we are going to sustain the leaps, the efforts that countries, implementing partners, communities are making with this DREAMS effort if this program is not supported.
So again, thank you for the comment. I can't see you, but Joe, but where is she? Anyway, oh, there we are. Okay, thank you, Joe. So financing it, well, I don't think it's exclusive one or the other, it's both. I mean, as Marelize had kind of indicated to us, described to us the situation in Nigeria, which is repeated in Tanzania, Uganda, other countries. You see it all over the world, where you have legal structures that make kind of these populations, these behaviors illegal. That creates huge problems. Financing, also a problem, even when you have situations where these behaviors are legal or kind of accepted, although illegal. It is still the case that funding for HIV is going to diminish. We've seen it already. It is happening. So particularly for the programs that I'm involved in Asia, that they're getting squeezed. Global Fund is giving less money on this round, so they're having to actually shrink their programs. And although in the grand scheme of things, they're small epidemics, locally, they're huge epidemics. They're huge issues for these families and these communities and the like, but they're getting squeezed. And so even with PrEP now is available, it's not cheap. So yeah.
Only available in 2 countries right now.
Okay, but it's even when people talk about it, we still have, as we saw on the chart, you look at coverage, treatment coverage for key pops, we still have up to 60% of the population we want to get into treatment, much less get into PrEP. So the technology, the methods are out there, the affordability of them, the lack of financing that's going to do it still remain problems.
Focus is right now, and I'm going to ask Stella to talk a little bit about what data and are available to give us a little bit more information about these key pops and how we can reach them, and what methods can we use to get more data and to use and analyze the data to help answer some of these questions. So we're going to talk a little bit more about the data aspect.
So thank you. So I think it's important to reach these groups where they are. For example, the men, reach them in their safe spaces where they feel comfortable. Instead of waiting for them to come to the health facility, maybe take the health facility to them. Mobile services, maybe also workplace services, door-to-door, self-testing, issues like that, where they feel comfortable. That is something that, we should be doing more of, which of course we are doing, but we need to do more of. We also need to be thinking about whom do they trust? Who are the people whom they can relate to? We need to use people who are sensitive to the peculiar needs of this. We need to use them more and more. We need to train anyone that is interacting with these people. We need to train them. For example, let's take the case of gender-based violence. Let's take the case of survivors of gender violence. It is, I would say, criminal for someone who is not sensitive, who has not been sensitized to interact with a person that is a survivor of gender-based violence. So in this case also, anyone, including providers, should be trained on how to interact with these special people. Another issue is, we need to be thinking about segmentation, audience segmentation. We are not just talking about, socio-demographic segmentation, which we should be doing, but also about ideational segmentation. How about, in terms of their health needs, in terms of, what stage they are in. We need to be thinking about collecting information that will enable us to segment, to segment them in terms of, their level of efficacy beliefs, their level of perceived norms. All these additional variables, we need to start thinking and collecting more information about those people. And then also look at even information about how do we reach them. What is their, for example, their social media habits, their media habits. Do they have telephone? We assume that everybody has one, but are they exclusive? And how often do they use it? Do they trust anything that comes on their telephone? We were doing a study in Nigeria, and the people were just not picking up the calls. Why? Because they receive 1,001 calls every day. And so they have just blocked their mind. I don't know the number. I'm not going to pick up the call. And, but cell phone is ubiquitous, but can we safely use cell phones? Because, the market is such that there's so much junk out there. So also, like I said, the factors that hinder these people operate at multiple levels. Are we collecting information at multiple levels? Are we looking at, the issue of political will, the issue of policy, the issue of for example, the attitudes of law enforcement agents, the issue of the community involvement, community ownership, community efficacy? Are we looking at the issue of, the relationship with the partner within the family and all that, and not just that individual, because the individual does not exist in a vacuum.
I agree with everything Stella said. I would only add that I think the point I made earlier may warrant some highlighting. The evidence that's missing is evidence on the how. We have a lot of the evidence on the what. It is about evidence on how. How do we reach these populations? How do we get programs implemented for these populations? How do we create demand for these populations? Which service delivery modalities, self-testing, home-based testing, provider-initiated counseling and testing, which of these modalities work best for these different, very segmented populations, as Stella referred to? Malawi is a quintessential example. So Malawi is hailed as one of the success stories, very rapid increases in HIV treatment in the last 5 years. But they've reached a plateau in terms of diagnosing, right? So if we talk about the yield rate in HIV testing, it's the number of people who are newly diagnosed as HIV positive out of every 100 people tested. As Paul said, these rates have plummeted. In South Africa, it used to be 1 in 5. It's now 1 in 15 or 1 in 20. Now, you might think that's a success story because there are fewer HIV positive people. On the one hand, it is, but on the other hand, it's because we have already diagnosed the easy to diagnose, right? We've diagnosed sick people, we've diagnosed pregnant women, we've diagnosed people who interact with health facilities or who come to health facilities. Reaching the second 50% of that first 90, which is not getting people tested. It's not a population level indicator, it's a diagnostic indicator. 90% of PL HIV being diagnosed, right? Getting to that second 50% is going to be extraordinarily difficult, and we just don't yet know how to do that. In Malawi, 69% of people who get tested for HIV are pregnant women who get tested in health facilities, and most of them are repeat testers, right? So we're not reaching men, we're not reaching key populations, we're not reaching populations in prisons, we're not reaching those hard to reach populations and finding out the ones who are unknown but HIV positive, diagnose them and link them to the care system. And I think this links to a broader point about the challenges of primary health care for men. We've done phenomenally well, I think, in general with the Millennium Development Goals, right? Millennium Development Goals had a very strong focus on maternal and child health. But what that meant is that we created primary health care, particularly in Africa, that is very well suited, and where a woman or a pregnant woman or a woman with young children feels very welcome when she walks into a primary health care site, because those are her peers are in that health facility with her. We've not created primary healthcare services or sexual reproductive healthcare services for men in Africa in general. And again, so we can't just think about the HIV services, be it male circumcision, be it testing, be it treatment, be it adherence support that we provide. We have to think about all of healthcare that we need to provide for men. And I think that is going to be one of the real challenges in the next decade, two decades, particularly in Africa, is creating male-friendly and male-relevant and male-demanded healthcare. So that would be the only thing that I would add. Thanks, Anna.
Hi, my name is Elizabeth Rowley. I work with PATH, gender and gender-based violence researcher. And thanks to all of the panelists for two sets of discussions that have been really interesting. And my question actually is kind of bridging both panel topics. And in particular, in the earlier panel, we heard a lot about some of the challenges in evaluation. And I'm interested in hearing more about the DREAMS initiative and implementation science under the DREAMS initiative, as well as any of the other panelists' experiences. But oftentimes the time frame for evaluating quite complex change processes is shorter than optimal, to say the least. And I think the DREAMS initiative has a pretty tight time frame. So I was curious to hear how that's impacted evaluation approaches in terms of what has been possible and what hasn't been possible.
Thanks, Elizabeth, for that question. And we work with PATH in some of the DREAMS implementation science work in Kenya, so we can chat after also. The audience may not know, the DREAMS initiative was launched in 2014. It sort of officially is coming to the close, I think, in 2017, but there might be, hopefully, some renewal of some of those efforts. And so that created a really tight timeline for all impact evaluation and implementation science studies. And the outcome that Ambassador Birx had placed for DREAMS success was I think a 25 to 40% reduction in HIV incidence. Now, in order to calculate HIV incidence, you need data at multiple time points and looking at who has seroconverted, who has acquired HIV within a given period of time in a given location. So that in itself limits where you can do impact evaluation looking at incidence rates and changes in incidence rates. So the groups that are doing the impact evaluation studies, London School, Epicenter in South Africa, London School in South Africa, in Kenya and in Zimbabwe, with several local partners, are looking at sites where there was existing demographic surveillance data and HIV biomarker data collection in order to be able to look at what has changed within that time period in the sites that were selected for DREAMS. The other thing that PEPFAR is working on with Columbia University is the HIA, I think they're called HIAs or FIAs, but they're basically HIV serobehavioral surveillance surveys that are representative at the subnational level, so different than the DHS or AIDS indicator surveys. And they're supposed to be implemented more frequently, and they're using lag avidity and other assays to get incidence from prevalence data collection. So there's some of that really innovative work is happening, and I believe some of the country level results are out. For the implementation science work, we are looking not only at, we're looking at who has seroconverted, but we're not doing that through biomarkers. We're asking people who have, if you're HIV positive, but we're collecting all of the data that is associated with HIV acquisition. So all the behavioral information as well as the social contextual information. And the challenge really has been trying to work very closely with implementing partners to really figure out how they're implementing a fairly complex and comprehensive intervention and what effect that will have on the girls' lives. So, the implementation and research timelines are not always the same, so we were trying to move very quickly together. And we're using a mixed methods approach in almost all of our studies. So we're doing both quantitative data collection, either with the girls themselves, with their male partners, with healthcare providers, as well as qualitative data collection with program implementers. I remember somebody in the audience in the morning asked about, what do you do when multiple things are happening in the same site? How do you do attribution? And that's part of the challenge of DREAMS. So not only is DREAMS implementing multiple layers of intervention. So for example, they're doing life skills building for girls, condom promotion for girls. They're also doing a parenting intervention. They're also doing a secondary schooling intervention. There might be a different agency providing HIV treatment and care. A lot of that we're trying to capture through work with the implementing partners and documenting what they're doing to set up the program, how they're rolling it out, their timelines, their staffing structures, how they're layering and leveraging their efforts.
And I think actually the DREAMS effort is actually kind of a good example. It's a reflection, I think, a lot of what we've seen. Well, again, what they've seen in PEPFAR. That PEPFAR has supported implementation science impact evaluations and any number of names that have been used for years, but it's always been a huge struggle, both to ensure quality of the study, but also to ensure timeliness. Because often you get a good quality proposal, you anticipate 2 to 3 years, it turns into often 4 years, sometimes 5 years, at which point a lot of this is no longer relevant. So it's never been done successfully. And we may see some of the same consequence in DREAMS because they're very sophisticated studies and very expensive studies. Some of these population-based subnational HIV incidence studies are tens of millions of dollars. So you have competition. What do we use resources for? And which I don't know the right answer. But I think this gets kind of more broadly into the case, a little bit of what my colleague has said earlier in terms of trying to find out quickly how do we find these populations? How do we deliver services to the populations? Go to them, don't have them come to us. Innovation. I mean, that is so vital to the work that we're doing, and it's a rapidly changing environment. So how do we innovate, and how do we test that innovation in a timely way? And again, I don't think we have the full answers, but we've got to be much more creative and perhaps much more lenient in terms of the type of study that we do and the expectations regarding impact. Impact interpreted both as incidence and both as randomly controlled trials. But in that, unless we do that, we're going to get caught up in these very intensive, very sophisticated, actually very strong studies, which are very important, but perhaps we need to be more selective. That if we're innovating, trying a new method in the implementation of a program, we've got to be more willing to say we don't need a full-on RCT. We need something less than that that's going to tell us, are we doing better at what we're trying to do?
This is a challenge that we face every day because the funding runs out before the project finishes, before we can actually document any impact. But I think something that we could be doing more of is theory-based evaluation, theory-based, so that if we know exactly how the project is supposed to work to produce the impact, then collecting information on those intermediate parameters might help us. So we need to get our theories right. We need to know exactly how does this work to produce the result. If this is supposed to change the use of condom use, and our intervention is not changing that. Then maybe at the end of the day, it's not going to change incidence. So if we don't have enough time, we need to get the theory right and do the right thing at that level.
I would only add to that maybe an example in the World Bank, we increasingly in our impact evaluations and in our work on evidence insist on what we call an evidence cascade. So we would start, and I have an example from South Africa where we started with a study on treatment adherence. But the first thing that we did was to support the government in analyzing 44 million records from the National Health Laboratory Service to look at what do we currently know about adherence levels, viral load detection, viral load suppression. Then we moved from big data to looking at all the routine data and what do we know from routine data and qualitative work with people who are on HIV treatment about adherence. Moving from that to very rigorous documentation of baseline data that immediately already fed into policy. I think sometimes in impact evaluation we are detailed, methodical data perfectionists, right? And sometimes we can let the perfect be the enemy of the good. And I think we need to work on this evidence cascade in incrementally, not just building evidence, but incrementally disseminating and sharing evidence as we go along and not wait for that perfect 5-year impact evaluation, randomized controlled trial to give us results. I think the second thing that can help to bridge that gap between theory and practice or theory and implementation is to evaluate real life implementation. So it's easier, I'd say, not easy, easier to give a researcher a truckload of money and say, go implement the perfect intervention and evaluate whether it works, right? We need to do more of real world impact evaluations. In the ones that I'm involved in, for example, we have government co-principal investigators, government implemented programs. Yes, there are many more hurdles because we as the researchers don't control the intervention. So the intervention is implemented much less perfect than if we had complete control over the intervention, but it also means that we get results much more rapidly. In Malawi, I was sharing with Anna earlier, we had a male circumcision demand creation study that showed very good results, and the government was co-principal investigator, led the study to the extent that when we shared with them the first preliminary results, they were so amazed at the results that in their national male circumcision policy, they've already made changes to accommodate this new intervention before we'd even academically published it. And we know typically the gap between publishing evidence and it being taken up into policy is 5 to 7 years. It's possible to shorten that gap if we do some of these things. I think we need to get creative with our methods. Small studies, synthetic controls, for example, is an area we're increasingly using because we don't need these large sample sizes that we need in impact evaluations. I think we also, and sorry, that was the 5th point, I think we also need to encourage implementers to publish. My experience in working with implementers is that they are impatient and don't see the value in publication, right? There are great journals, Global Health Science and Practice, that your ex-employer and USAID is supporting, Paul, which is a great journal that's all about documenting implementation practice when you don't have a scientific impact evaluation design, right? We need to encourage them more to implement. And then the last point I would make is that I personally think that in an integrated sustainable development goal universe, we are moving further and further away from this notion of single interventions with single outcomes that we can easily evaluate. I think as the impact evaluation community, we need to recognize and embrace the complex world we live in, and we need better methods. I hope that in 10 years from now, we don't talk about attribution as much as we do now, right? Not just attribution of what did my development dollar buy versus yours, but because we know interventions are more integrated. People are integrated human beings, and these single interventions with single outcomes, particularly because the standard of care in our control groups are often so high, becomes more and more difficult to do. I did want to respond to Richard's question about money. Richard, I would turn the question somewhat around in that I don't think it's whether government should borrow for health. It's whether governments want to borrow for health, which I think is a whole different discussion. Thank you.
Just wanted to say that I agree with all the points the panelists made regarding the evaluation work that needs to be done, definitely theory driven, and I think that theory becomes really important as you go to these more complex interventions. Understanding how you're expecting what is your theory of change and what you're going to assess. I also wanted to say that I think we do need to think of beyond RCTs because we're not always able to assign people to control groups. And there are innovative methodologies. For example, the council's implementing a study in South Africa that is using a step wedge design. So it's working in an implementation setting with implementers and looking at where the same group is used as a control over time. And so there are different ways of thinking about creating the right kind of evidence that can feed into programming. And I think the last point, I don't know if we're going to get to this, is really, I think I wanted to confirm what you were saying about research utilization and how to do that effectively. We don't want, actually I think usually the gap sometimes can be like 20 years. We don't want any of that gap.
Yeah, exactly.
And what has worked well for us is early engagement of stakeholders. So I'm actually going to Kenya and Zambia next week and the week after, where we are sharing baseline, partially analyzed data with key stakeholders. So the program implementers, the Ministry of Health folks, our donors, other funders in country to say, here's what we have. Is this different from what you already know? How does this expand your knowledge about this community, about this topic? What more needs to be done? So I think those kinds of really on-the-ground research utilization processes need to be put in much more routinely into the work that we do.
We have a 1-minute comment from each of the panelists to sort of sum up their views about how we can get and use and disseminate information about subpopulations and distinguish the between the different groups and some of their differences.
Maybe just to say that part of our challenge as folks focusing on evidence is, whilst on the one hand, the absence of evidence is not evidence of absence, there are sometimes things that we have to do that we have to stop doing, right? Sometimes our evidence points to things that are not working that we should no longer do. And I think that is, to me, something that doesn't get reflected often in discussions. We discuss more evidence. What do we need to do better? What do we need to do more of? But the flip side of that coin, de-investing in unproven things or things that do not seem to work or things that do not yield the successes that we do is hard to do. And I think as folks focusing on evidence, that's maybe a collective challenge for all of us to think about in our own work. How do we make those, not just adopting new things into policy? We all want the shiny new thing to add to our policy, right? But what are those old things that don't work that we need to take away from our policies? And how do we do that in a way that recognizes the political economy and the vested interests in those unproven things that often still get implemented? Thank you.
I just want to make 2 points, and that is we need to make better use, more creative use, or be more creative in our use of existing data. It's not every time we need to collect new data. There is a lot that can be learned, for example, from the DHS, from surveys that other people, other organizations have done. We could do more creative data analysis. Another thing is community ownership, even community ownership of the data, community ownership for even the process of collecting the data. Because at the end of the day, projects come, projects end, and at the end of the day, what are we leaving behind? We need to think about building the capacity. We need to think about them, being part of the evaluation, being part of the generation of data, and being part, of using the data.
I guess which everyone here does, recognize that these are complex issues with many dimensions to them that I think we've seen various elements of these kind of addressing this. So I'll just pick one, which is the utilization of, it's not data that we necessarily have, but isn't hard to get. It's actually, so shifting our focus from a lot of these kind of large-scale surveys to looking at programmatic data. but in many cases, we don't have some of the data that I'm thinking about, which is our ability to actually kind of monitor the full continuum of care among key populations. We have some of the key moments in it, but we can't tell clients X whether or not they were the ones that actually went from testing to enrollment in care to viral suppression and so on and so forth. So there is an increasing expansion of what are called real-time monitoring systems that actually allow us to do this. They link different service providers and you can follow patients kind of along that trajectory and see whether or not individuals actually get through this system. This is something different than kind of client-based medical records, and it's different than these more aggregate systems, but it's a good linkage between the two. And so we, as in our programs, are beginning to actually try to implement some of these, but we see great potential, and particularly not only to figure out whether or not our programs work, but it can also help us, I think, respond to some of the kind of larger questions that we ask in these surveys that we conduct. I mean, we've got to come up, as everyone I think recognizes, we need alternatives, and some of these, some of the practices that we currently have, so it's getting rid of some of these things that don't work and that are overly expensive. We just can't do them anymore. So we need to be more creative and more innovative.
I will champion the comment earlier around recognizing the heterogeneity of the populations that we're working with and the importance of segmentation and thinking about particular vulnerabilities in particular locations that people are situated in. At the same time, we shouldn't all be entirely negative. There are some amazing people who do manage to access services even though they're highly stigmatized, even though their behaviors or they themselves are criminalized. And I think an important piece of work that we could be thinking about is really around positive deviance. Why are these folks able to overcome the stigma, the discrimination, the barriers in order to access services, and figure out whether those facilitators can be expanded? Can we build upon them? And I think, as we've already said, it's really important to talk to people about what they want, the different heterogeneous. But then equally important, because here we are at 3IE, to test those strategies. People will tell you over and over again, I want information from my friends. Their friends may not know anything. So what is the right way of getting their friends to get them the right information? What is the right modality of that? And so I think that is our job as researchers in figuring out whether those strategies work outside of clinic settings, outside of randomized controlled trials in the field, and feed that back in quickly to programmers and policymakers.
So thank you very much to the entire panel. It was absolutely wonderful to have you all here today. And I hope that everyone has enjoyed this discussion as much as we have.